Welcome to this high-yield review on VT Storm Management. I'm Dr. MedEd, and today we'll break down the emergency and long-term care strategies for this life-threatening condition. Let's jump right in. What is VT Storm? VT Storm is defined as 3 or more episodes of sustained ventricular tachycardia or ventricular fibrillation within a 24-hour period. These episodes require interventions such as cardioversion or defibrillation, and the condition carries a high risk of mortality. It's a true medical emergency. Initial stabilization. Start with your ABCs: airway, breathing, and circulation. Place the patient on continuous cardiac monitoring. Establish IV access, provide oxygen, and draw labs including CBC, CMP, magnesium, troponins, and a toxicology screen. If the patient is unstable, with hypotension, chest pain, or altered mental status, proceed with immediate synchronized cardioversion. Let's talk medications. Start with amiodarone, 150 milligrams IV over 10 minutes as a loading dose. Then continue with an infusion, 1 milligram per minute for 6 hours, followed by 0.5 milligrams per minute for 18 hours. If needed, use lidocaine, 1 to 1.5 milligrams per kilogram IV bolus, then repeat doses of 0.5 to 0.75 milligrams per kilogram every 5 to 10 minutes, with a maintenance infusion of 1 to 4 milligrams per minute. Procainamide is another option. Administer 20 to 50 milligrams per minute until arrhythmia is controlled, or you reach a maximum dose of 17 milligrams per kilogram, or hypotension develops. Don't exceed 15 milligrams per kilogram or a total of 1.5 grams. And don't forget your electrolytes. Keep potassium above 4.5 and magnesium above 2.0. If magnesium is low, give 2 grams of magnesium sulfate IV over 15 to 20 minutes. Sedation and sympathetic blockade. In patients with frequent shocks or adrenergic surge, sedation is essential. You can use midazolam, 2 to 5 milligrams IV, or propofol, starting at 5 micrograms per kilogram per minute and titrating as needed. If tolerated, beta blockade with esmolol is effective. Give a 500 microgram per kilogram IV bolus, followed by an infusion of 50 to 200 micrograms per kilogram per minute. This is especially useful in catecholamine-sensitive VT. If pharmacologic measures aren't enough, escalate care. Consider temporary overdrive pacing. For recurrent or drug-refractory VT, catheter ablation may be needed. In cases of cardiogenic shock, mechanical support such as an intra-aortic balloon pump or ECMO can be life-saving. Long-term management. Once the storm is over, long-term care planning begins. This often includes ICD placement or reprogramming. Use cardiac MRI or coronary angiography to identify structural causes. An electrophysiology study can help guide further ablation. And always address underlying causes like ischemia, myocarditis, or electrolyte imbalances. To recap: 1. Recognize and intervene early. 2. Use a combination of antiarrhythmics, sedation, beta blockers, and correct underlying triggers. 3. Involve a multidisciplinary team, electrophysiology, ICU, and cardiology, from the start. If you found this video helpful, please give it a thumbs up and subscribe to the channel. Drop your questions or your clinical experiences with VT Storm in the comments. Let's learn from each other and grow this community. Thanks for watching.